and talk about something that I'm sure is on a lot of people's mind, which is the Brainstorm Neuron therapy. As I mentioned in the timetable slide, we were a site for their phase 2 study, and then we were also a site for the phase 3 study. And as you know, the top line data that was reported by the company and Dr. Sukovich in December at the ALS MND meeting did not meet statistical significance. And they've been in conversation with the FDA regarding paths to go forward. So in many ways, the NEURON MSC therapy is they're similar and different in some ways. So NEURON cells come from the bone marrow, and our studies are looking at fat-derived MSCs. And there's still some controversy in the field as to whether those are equivalent types of cells. Some people think that they're significantly different, and other people kind of lump them together as all being MSCs. The other thing that's quite a bit different about what the NEURON cells do is that when right before they are injected into patient spinal fluid, they undergo differentiation into a different type of kind of broth that they're grown in that cause them to change their properties a bit. So they're not the straight out of the bone marrow grown up and sent back into the spinal fluid. They change them a bit after they've been out of the body. And that's different than what we're doing, where we're basically taking the fat-derived MSCs, growing them up and putting them right back into the body, and not doing anything special to try to enhance their effects before re-injection. Now, you could argue either way whether it's one's better than the other. I think, ultimately, hopefully we'll be able to get to some answers within the science to determine in patients whether one's better than the other or whether they're equivalent. And I think the jury is definitely still out on that. All right, and so this is the layout of how the phase 3 NEURON clinical trial was designed. Again, kind of looking along here, there were 14 visits. At the green squares at 0, 8, and 16, there were 3 injections of autologous NEURON that were injected intrathecally, and then follow up out to the final endpoint, which was week 28. And again, these are autologous cells taken from a patient's bone marrow. And so these are the slides that they shared with me and allowed me to present. These are the same slides that Dr. Sukovich presented at the ALS MND meeting. So this is all public knowledge. And this shows, again, kind of a responder analysis where showing at each week what were the percentage of responders, and that's defined as increasing by 1.25 per month slope on the ALS FRS from pre versus post treatment. And so you can see at week 2 and all the way out to week 28, there was always more responders in the NEURON group versus the placebo group. Now, as you can see, p-value, this is what we call statistical significance. And typically for scientific studies, we like to see a p-value at 0.05. And so 0.45 means that based on the numbers of patients that were in this group, it did not meet statistical significance. Now, there was always concern that again, there may be some groups that respond more than others, or that the ways that we measure progression in ALS have some flaws associated with them. So they decided before even going into the study that they would look at a separate group of patients who were a little less affected at their baseline. So having a baseline functional rating score of greater than 35 out of 48, and compare that group to those who at baseline were more debilitated by ALS with a functional rating score of less than 35. And it became evident that when you looked at it this way, that a lot of the effect that you were seeing in the combined data was being kind of buoyed up by the patients that had a lower FRS score at baseline. And so if you look at the bottom graph, those with the low FRS, it was very similar between NEURON and placebo. Whereas if you look at the group up above that had the higher FRS, that the NEURON was doing much better. It still didn't meet statistical significance, but it was a much more dramatic change. And one could hypothesize that if you had more patients in this upper group of greater than 35, you might have seen statistical significance. And, I think there's a lot of discussion in ALS clinical trials more broadly about trying to balance the ability to include as many patients in as many clinical trials as possible, basically, opening up the trial criteria very broadly so everybody has a chance to be in clinical trials, which I think is an extremely important goal to attain. But recognizing that what comes with that is that it becomes very hard to differentiate between patients who are responding to an ALS therapy to those that haven't. And when I say that, part of the issue is that there's, as you all know, there's quite a bit of variability in the rates of progression in ALS. And so patients within that population, some have very fast progression, some have very slow progression. And, I think when you look at the data that was put together in the Darabone study or the Radicava study, they basically designed their study in a way that was going to be the very most likely to find a positive result if it was there. So it was very designed in a very clever way. And it's kind of, basically the patients had to have widespread disease, but it had to be pretty mild. So what that means is that it was widespread, but it was still functional. And so when they were measuring the functional rating score over time, it had room to drop. So, if you have an area of ALS FRS that's scored between 0 and 4, and if you're at 0, you can't go any lower. And so you're not going to be able to measure anything lower than where you're at from the beginning of the trial. So in the Radicava study, they made sure everybody was above 2 in each domain, so they had room to drop. And they had to be patients that were shown to be progressing. So they knew they were going to progress during the time of the clinical trial. And so what they ended up with that was the ability to detect changes very readily in a pretty small group of patients with ALS. Now, it meant that it was a very restricted group. They didn't enroll very many patients and very wide ranging types of patients. So these are the kind of the conflicts I think that we run into. And I think that the NEURON study, at least in the way I've seen the data here, is that they may have fallen into that same challenge where there was too much variability in the groups of patients that were enrolled in the trial. And it made it impossible to detect the difference based on that. This is the last slide from the Brainstorm group, just showing how the ALS FRS changed over time, kind of as you look at each group over the time of the trial. And so the blue is the NEURON and the red is the placebo. And again, the groups that were above 35 showed more change than those below 35.